it's across the board. We are a very multicultural society in Australia, and health practitioners need to be able to adapt the way we deliver healthcare across the board.
Hi everyone, and welcome to Mug of Science, a Pint of Science initiative here for 2021. My name is Natai, and today we are filming from the lovely Ourimbah campus, particularly at the Yarning Circle at the Ourimbah campus of the University of Newcastle. And I'm lucky enough to be joined by Professor Vivian Shooter. Viv is the head of program for the podiatry program. And today we're going to be talking about all things science and podiatry. So Viv, welcome. Thanks for joining us.
Thanks for having me, Natai.
We start every interview with the same question. We're running an informal survey about what scientists tend to drink, either for their morning or afternoon beverage.
Okay.
So the first question, as always, is what is in your mug?
Generally coffee.
Generally coffee?
Generally coffee, unless it's after 6 p.m, and then who knows?
Then who knows? Then it's party time.
Yeah.
Yeah, great. All right, Viv, well, why don't you tell us a little bit about yourself, who you are as a person, what brought you to science, what led you on the path that you're on now?
Well, I'm a podiatrist. For those of you who aren't aware, podiatrists generally treat feet and injuries of the feet and legs. I started as a podiatrist quite a while ago now, and I started working in clinical practice. And what I found when I was working in clinical practice was that I had a lot of questions that we didn't really have good answers to, particularly about the best ways to treat people, the best ways to assess certain injuries, and how we can get the best outcomes for our patients. And that's what really got me into science and got me into doing research. And that's what made me decide that I wanted to take on a career in teaching people about podiatry and also furthering our knowledge of podiatry in terms of medicine and how we can improve outcomes for our patients in the future.
Yeah, I feel like the foot is often an overlooked part of the body. It's a bit of a workhorse, and I don't think it gets the attention or the respect that it deserves. Was there anything did you have an ankle injury or a foot injury when you were young, or is it something you just fell into?
Yeah, that's a really good question. It's very much something I fell into, but when I was choosing a career that I wanted, I originally thought I wanted to be a health practitioner purely, as opposed to being a clinician and a researcher. But I think I originally wanted to be a health practitioner because I wanted to help people. And also I decided to be a podiatrist because I discovered podiatry from my neighbour, who was a podiatrist at the time, and she told me about a big variety of things that she saw in her practice, and it got me interested in thinking about the different ways that we can contribute and the different populations that we deal with. So as podiatrists, we will treat children, we will treat very elderly people, we will treat really chronically ill people, we can treat sports people. So it really depends on what you're interested in and what area you want to go into. So the scope of what I could do was what attracted me to being a podiatrist specifically.
Yeah, that's really interesting. I'm just wondering if you could maybe, before we get into the research side of things, just tell us a little bit more about the scope of practice for a podiatrist, because I've heard they're almost like a mix between a nurse and a GP and an allied health professional and a physio, all kind of mixed into one. And the things you have to do day to day are actually quite broad and quite individual, I guess.
Yeah, and that's very true. I think it's probably not widely known that we can deal with highly clinical medical problems. So we deal a lot with people with diabetes, with foot ulcers. We're really involved in preventing amputations in really ill people. But then on the flip side of that, we also deal with children's injuries and growing pains. And then in the middle of that, we have people who might have occupational injuries, we have sports people. So we just have this scope of practice that encompasses musculoskeletal and medical problems. And so we reflect a lot of different professions all rolled into one. And we have great opportunities now as podiatrists that we can specialise in the areas that really interest us, which is wonderful.
So it's not just insoles.
Not just insoles. No, not just insoles, not just toenails. They're only a tiny fraction of what we do.
Great. So are there any projects that you're running at the moment that you want to discuss in a bit more detail? Like you spoke about foot ulcers and is there anything?
So I run some research around diabetes-related foot disease.
Yeah.
So foot disease and diabetes is probably also not very well recognised in the general community. But people with diabetes are really at risk of developing severe conditions in their feet that can actually result in them losing limbs and can mean that they die a lot earlier than they should. And so a lot of our research is around determining better ways to assess people, to identify the people who are at risk of developing these foot complications, and also better ways of actually preventing people in the community developing the foot complications. We have so many people in the community now who are living with diabetes, who are having to manage it on a day-to-day basis. And what our research is trying to do is give them things that they can easily implement themselves. So things like simple exercise that can actually help reduce their risk of developing complications that could end up in them developing a foot ulcer that leads to an amputation. I think one of the things that's been hard for podiatrists previously is knowing the best way to actually assess these people coming into our clinic. So what test is the best test to decide if the blood flow to the foot is enough? What test is the best test to figure out if they can feel enough to protect their feet? Because people with diabetes can have problems with their circulation, they can have problems with their sensation in their feet, and so it means they can step on things and not feel them. So it's not uncommon when you're working in a high-risk clinic and dealing with these people that they will come in and they've stepped on a drawing pin and it's still in their foot when you see them in the chair and they have no idea it's there. So identifying better tests make us better at our job. And so we can, a group of people, so we could have a whole lot of people sitting in a room with diabetes, and from these tests we can pick the ones that we need to really worry about. And it's like, okay, this group of people over here are at really high risk of developing these complications. We need to look after you especially well. You need to come and see us more frequently because we need to do a lot of different things to try and stop any of these things progressing to the point where you're at risk of losing a limb.
Yeah. And I guess it's all interlinked, like, again, and just showing the role that podiatrists can play in an allied healthcare profession. I mean, I think of diabetes and I think of lifestyle interventions such as, nutritional interventions or exercise, but if they develop, issues with their feet because of poor circulation and then they can't exercise, that's an aspect or a perspective that I hadn't really thought of before, and really important.
Yeah, so it can make it really challenging for people with diabetes who have foot complications to actually perform those activities that can help them stay healthy. So part of our research is actually trying to figure out which are the safest ways for them to be able to do exercise, for example, safely, because we know that exercise has a whole lot of health benefits, but it also can potentially help with things like wound healing. And so we want to be able to keep these people active despite the fact that they might have foot disease, to try and prevent anything getting worse and to try and help them stop all the other complications that occur as a result of diabetes. A lot of our research we're doing now is also in Aboriginal and Torres Strait Islander people, because they have far worse outcomes from diabetes than the general population. And what we're looking at in that population is ways that we can actually support them to achieving better health outcomes in systems of healthcare that actually suit them a whole lot better than our general models that we use for everyone.
Yeah, that's really interesting. So you mentioned a couple of assessment techniques and different forms of exercise and maybe some specialised care for Aboriginal and Torres Strait Islander people. Can you elaborate a little bit? Like, what kind of assessment tools have you found to be effective, and is there a specific form of exercise?
So what we've found is that some of the ways that we assess whether or not people have got disease in the arteries going to their legs are better at picking it up than others. So probably one of the ways we have typically assessed in the past is by taking pressures at the ankle and the blood pressure at the ankle. And what we've found from the research is that that doesn't always pick it up in people with diabetes, because they have other changes that happen as a result of diabetes that affect those ankle vessels that stop us taking accurate measurements. And we've found that measuring at the toe, for example, is probably going to be better able to detect whether or not they've got any kind of disease. We've also found that people who have neuropathy have worse skin blood flow. So when we measure skin blood flow, we use something called a laser Doppler, and that actually picks up the blood flow in the very tiny capillaries in your skin. So while the large arteries can seem okay, when we get down to these tiny, tiny little vessels, sometimes they are not as healthy as they could be. And when they lose their sensation and their nerve supply, they don't work as well as they could. Now, this doesn't seem like a big problem generally, but once you develop something like an ulcer, we actually really rely on those tiny, tiny blood vessels to be able to open up and to be able to get more blood there and more white blood cells and be able to kill off any infection and actually encourage that wound healing. And if we've got neuropathy, it's potentially that's not the case, that's not happening as it should. So what we're looking at is whether or not something like exercise, so doing simple exercise, like could be bike riding, stationary bike riding, it could be walking, whether that can actually encourage those blood vessels to behave more normally. And so when there is injury to the skin, they open up, they get the blood flow there, and they actually promote that healing response. Because if we get good healing, then we're not going to end up with those outcomes like where we're losing limbs and losing toes.
Yeah, it's all about blood flow.
It is all about blood flow. Yeah.
So you mentioned kind of cycling as a potential form of exercise that might be good at mediating or improving that blood flow without maybe exacerbating kind of symptoms of the foot. Are there any other kind of interventions that you're working on at the moment?
Well, there's a couple of different ways because we can actually try and prevent complications with exercise. Some of them relate to exercise where we're doing cardiovascular exercise, so exercising our heart and lungs. Some of it relates to being able to stretch our muscles out. Because one of the things that happens when we have diabetes is our tendons and our joints get really, really stiff. So we have all this extra glucose running around our blood, so the sugar in the blood that we can't get rid of. And it upsets the fibres that are in the tendons, in the skin, so the collagen fibres, and it changes the way they sit next to each other. So they link together a bit differently, and it makes those structures really stiff. And so that stiffness actually then affects the way we walk. So it makes our toes claw up, and so then we get high pressure areas under our toes. It makes us load up our forefoot, so under the ball of our foot, because our Achilles tendon, the big thick tendon at the back on our heel, gets really stiff, and that actually increases the risk of developing a pressure wound under that part of our foot, and that's when we can go on and develop things like an amputation. So what we look at is ways that we can actually try and alleviate that process. So stretching a muscle, so a simple calf stretch, we've been looking at to try and increase our range of motion at ankle joint to get a more normal walking gait, and also to try and reduce some of that forefoot pressure. So it's about trying to, I guess, using exercise in all its different forms to try and target some of those complications that we're getting, and also get the general health benefits, because exercise is medicine.
I always say that every form of exercise imparts its own specific type of stress, and the body will adapt to that in a specific way. So using multiple different forms of exercise is generally the way to go. Great. So I guess you also mentioned specific needs of Aboriginal and Torres Strait Islander people in this area. Is there, would you like to elaborate on that a little bit as well?
Absolutely.
Yeah.
So in terms of diabetes for Aboriginal and Torres Strait Islander people, the outcomes are a lot worse than for the general population. They tend to have more foot problems, and it tends to affect them systemically more, so they get worse complications. So it might be in their heart, nerves, kidneys, so they have a lot worse outcomes for their entire body, and therefore a lot worse health outcomes. So, and what we find is the way that they access healthcare is a little bit different to, I guess, a Western model of healthcare. So we set up all our hospitals and everything because we think, well, that's the way we like to go. We like to turn up to an appointment at a particular time, and we're used to this model. But this model is not suitable for everyone. So different cultures have different needs and different expectations, and it doesn't necessarily, the way we deliver healthcare doesn't necessarily meet the requirements of what Aboriginal and Torres Strait Islander people need. For podiatry, and in particularly in relation to foot health, we've got a few different clinics around the country that have been set up specifically for Aboriginal people. So we actually asked them, what do you want?
Yeah.
How do you want to get this?
Yeah. How can we help you?
How can we help you? We want to help you. And help you and your feet feel better.
Yeah.
And that is a really effective way of actually getting them what they need. So a lot of our research is about finding out how we can best support Aboriginal and Torres Strait Islander people to get better health outcomes. So the specific things they need in the way that we deliver healthcare, the service types that we need, the people that they want in there, and what they are worried about, and what we can do to help them overcome the things that are a problem to them. And I think for us in podiatry, this is a really evolving process because we've only just started this journey, and it's about learning how to deliver culturally safe care, where people feel safe coming to get care from you. They know that you understand what they want and that you're willing to listen to what they want. And that is part of something that we'll be going through for many, many years to come, because becoming culturally capable as a health practitioner is a really important thing for any health practitioner in Australia, in any country. But for us in Australia, to try and help Aboriginal and Torres Strait Islander people have the same health outcomes as the rest of us, to live as long as the rest of us, it's really important that we take a good hard look at ourselves and the way we deliver healthcare, and actually start to listen to what they need and what they want, and how we can better deliver healthcare for them.
Yeah, it's definitely not a one-size-fits-all type of situation.
It really isn't.
No, we need to tailor our interventions for specific populations. So,
absolutely. And you know, it's across the board. We are a very multicultural society in Australia, and health practitioners need to be able to adapt the way we deliver healthcare across the board.
Yeah, very true, very true. Hi Viv, so thanks so much for your time today. We like to finish all of our interviews with the same question, which is, complete this sentence. For me, for you, a scientist is someone who
asks hard questions and goes and finds the answers.
Yeah. Does the things that no one else wants to do, the hard questions. Yeah. Great. All right, Viv, well, thanks so much for your time today. Thanks everyone for tuning in to this episode of Mug of Science. I hope you enjoyed it. Please keep checking the website for daily episodes, and we'll see you in the next one.